Institutional review board members who review AI protocols are experiencing a specific kind of helplessness. They sit across the table from sophisticated algorithms, reviewing clean data pipelines and impressive validation metrics. And yet, if they know where to look, they can see exactly how that tool is destined to fail a minority patient 2 years from now. Reviewers often stamp approval on these protocols anyway. This happens because the individuals at the table lack the frameworks and institutional authority to stop the project at the design phase. They are forced to document a disaster in slow motion. The global research landscape is currently trapped in a structural mismatch. Most oversight boards are trying to use a map of the 1970s highway system to navigate a SpaceX launch. The terrain has changed, but their toolkit remains static. IRBs themselves are not the source of the problem. An outdated framework has turned them into passive accomplices to downstream algorithmic harm. To understand the failure, we have to look at how oversight bodies define risk. In a standard clinical trial, analyzing risk is straightforward. When a patient tests a new drug, the intervention is physical. The risk of toxicity or adverse side effects is acute, localized entirely to a consented participant at the exact moment of exposure. This diagram illustrates the contrast between that traditional model and AI medical research. AI research inverts this architecture. Training an AI model begins with extracting a medical record or a data point. The initial intervention is painless and invisible to the data subject. Because of this, IRBs frequently default to minimal risk determinations and issue consent waivers. The true toxicity of that data, the embedded biases, the lack of representation, the missing variables, lies dormant within the algorithmic engine. The risk is deferred, and it reconcentrates downstream. It strikes the future patient who receives a clinical recommendation, a patient who never consented to participate in the research. A bad drug hurts the person who takes it during the trial. A bad AI model hurts the person who is compared to the trial data years later. Treating AI data extraction as a harmless administrative task creates an institutional blind spot. It allows research to proceed without safety nets for the physical harm deferred to future patients. Faced with downstream risks, some reviewers and researchers rely on a specific clause within the common rule as an escape hatch. This document shows 45 CFR 46.111, which instructs boards to ignore the possible long-range effects of applying knowledge gained from research. Some argue this means downstream algorithmic harm is outside their purview. The long-range effects clause was written in 1991 to prevent IRBs from becoming political censors. It was designed to protect sociological studies from being blocked simply because the findings might lead to changes in government welfare policy or public opinion. The rule exists to separate scientific inquiry from political pressure. It provides no license to ignore foreseeable physical or medical harm caused by a flawed tool. AI research produces functional products, triage engines, diagnostic models, and clinical decision support systems. Algorithmic bias, hallucination, and misgeneralization are immediate engineering failures. When an IRB approves a dataset that excludes certain demographics, the failure of the resulting tool is a statistically predictable consequence of the specific data choices made today. Applying a 1990s policy shield to 2020's algorithmic engineering breaks the protective mandate of the IRB, creating an oversight void where life-altering tools deploy without scrutiny. When that oversight void persists, the actual consequences hit the clinic precisely at the deployment phase. If an oversight body waits until hospital deployment to catch a systemic bias, the developers cannot simply issue a software patch. Consider a research team that spends 18 months building a medical model. They train it on retrospective data from a single, predominantly insured, white, suburban hospital. It moves towards clinical deployment. The failure occurs the moment the model is applied to a demographic it was never trained to understand, like low-income rural patients. The model cannot safely generalize. Fixing a foundationally flawed model requires scrapping the project entirely, sourcing new datasets to fill representation gaps, and retraining from scratch. This waste of years and millions of dollars in computing power is known as algorithmic technical debt. This debt accumulates because no institutional authority was empowered to look at the data and ask the hard questions early in the process. Relying on post-development oversight guarantees failure. To prevent technical debt, ethical intervention must be relocated to the start of the pipeline. The software industry identified the high cost of late-stage failures in 2001, when testing expert Larry Smith proposed a structural solution. Smith defined shifting left. He argued testing, quality assurance, and security checks must be moved as early in the development timeline as possible. This engineering principle applies directly to AI research in healthcare. The IRB must perform ethical audits on the proposed dataset before a single line of code is written and before medical records are extracted. Upstream oversight requires a framework of embedded design ethics. This approach treats demographic representation and bias mitigation as core engineering constraints from day one, rather than legal afterthoughts. By shifting left, IRBs transition into active, protective partners who secure the scientific foundation before the building process begins. This raises an operational question. How can a traditional IRB evaluate AI safety without needing to employ data scientists? The solution is a mechanism called the integrity bridge. Reviewers start by examining the left pillar, identifying the specific origins, limitations, and demographics of the proposed training data. Reviewers do not need to understand neural weights. They simply need to read the label on the data being used. Next, they examine the right pillar, defining the exact demographic the researcher intends to treat once the tool is deployed. Finally, the board evaluates the delta, determining if there is an unjustified gap between the training data and the target population. Consider a proposal where the goal is to deploy a triage tool for pediatric asthma in low-income, rural minority populations. The reviewer checks the foundation and finds that the researcher is using records from a high-resource, urban, predominantly white hospital system. The data cannot support the clinical goal. The bridge fails. This framework uses the mandate already present in 45 CFR 46.111, which requires boards to ensure procedures are consistent with sound research design. If the foundation does not match the clinical claim, the scientific integrity is broken. Approving a broken tool creates a phantom benefit, requiring the board to halt the research. The board functions as a logical auditor, verifying that the label on the data box matches the promise in the research proposal. By demanding researchers build a solid integrity bridge, IRBs step out of the trap of documenting disasters in slow motion. They become vital partners in building rigorous AI that safely serves the patient.